And then, non-reading is peculiar for the difficulty in attracting doctors. Even at teaching hospital, as my big brother is here, I know that those are called challenges. So it's something that the region is trying to attract them by, conscientizing the medical superintendents to, put on board certain special packages. And these packages may include what others will not get in other places, maybe in Accra or in Kumasi or Sunyani. Then among these packages, they also have the privilege of going to school early like any other person. So now you find doctors coming to work for someone 6 months or for 9 months, they're going back to school special. All in a bit of trying to attract them, let them understand that we are for them everything about them. Now, with respect to family physicians' role in the region, I think that it is something that you may need to improve. Just this morning, before I came in here, I was at the radio station to do an advocacy for Ghana Health Service a couple months, May, our mental health awareness month. And I didn't miss the opportunity to project family medicine. So I took the opportunity to introduce the fact that we are celebrating World Family Doctor Day, which took place on the 19th of May. And then we are having very important deliberation meetings right here at the Global Hotel to project the family medicine. And another thing too that is interesting is that when you go to the teaching hospital, one of our homes is also heading the corporate clinic. Oh, can she get a And right now, we are being told to include just gender mainstreaming into every policy in Ghana. Perhaps panel members here are all males. Maybe in the future we'll try to do a right thing. I have to mention it because gender mainstreaming has come to stay, and it's something that we need to take into consideration in organization of programs, inviting guests, and all of that. I believe that maybe next time we will do better. Now, when it comes to training at the family medicine directorate actually resides. We at the region have very good collaboration with them, and I sometimes join them in their meetings. When I have time, I join them even in teaching rounds. But we need to do more. Perhaps Ghana Health Service, we are ever ready to push doctors who want to pursue family medicine. At the moment, there's one doctor in one of the hospitals who came to see my office, discuss family medicine. Even though she hadn't applied for study leave, we are ready to go an extra mile to regularize the process so that she can actually pursue family medicine. So we are doing a lot. But we need to collaborate more as Ghana Health Service. Then another thing too is that when people complain that after completion of school, when they get back to their various facilities, they are not ready for them. So there comes the space. Which space in the hospital healthcare industry are they supposed to be? Are they supposed to work at the OPD? Are they supposed to work on the wards? Or are they supposed to work in theater? That brings about a lot of dilemma. But what I've done with those who are in Ghana Health Service in the region is that I, in my capacity, always would push for foreign physicians to be made head of facilities for reasons that we all know. One, as a family physician, during training, you are taught management. So we assume that once you come out of school, you can actually head a hospital because you have the management skills, because I also go through the same process. Even though after completion, they need to add on some courses, that effect. And then also, family physicians provide a unique perspective in terms of care. I can remember when I was a medical officer, anytime I call for an emergency, what I do is that I go straight to the pelvis. When I even the sea, I look for the bladder, I look for my catheter. But then, after family medicine, I gave him a different perspective. Now, when I come, the first thing I do is to ask of my team members. Because family medicine gives you an in-depth knowledge when it comes to care of the patient in a holistic, comprehensive manner. Furthermore, after adding on the anesthesia too, now when I also look for the airway. Because you realize that when you go for an emergency, when you go to the site or the locus, you may end up missing a patient who has a tongue that has fallen back, possibly choking the airway, and the patient may die even before you save the uterus. So what I'm trying to say is that family medicine practitioners are a special group of people. And some of us have never regretted that being a physician. They will continue their capacity in Ghana Health Service, the Northern Region, to advocate for family physicians to be made head of facilities so that hospitals can be managed in a comprehensive, continuous, collaborative manner. And then to end my part on this aspect, family physicians are skilled in stakeholder negotiation. In fact, there's a whole course of negotiation if you talk about negotiation. If you're head of facility or you hold a very important public office and you don't know how to collaborate, how to negotiate, you wouldn't make any headway. Because family physicians are so special when it comes to that. I've negotiated a lot, and I think that I am a direct beneficiary and testimony of the profession. Thank you very much.
So thank you so much, Deputy Director, Benekaka, Northern Region. Let me say, give a response. Prof, you asked about traditional medicine and then what is happening in the society. With family medicine, as part of the training, we have what we call complementary and alternative medicine. We know it has come to stay, and we have to know how to make all these things become part. Even we use what we call the biopsychosocial model, where we look at the clinical and then the psychosocial aspects. There are times that if the person thinks someone even prayed or whether imam, a pastor, that's the spiritual aspect, because WHO talks about our health to also involve spiritual. The psychosocial, the context in which the person stays matters, and all the things that are either impeding early detection or prevention, we take them, bring them into, and how they interfere with care, we make sure we address all of them. So as for the practice, it is context oriented, and then the fact that we have herbal medicine and all that is happening, we are fully aware. We are always there to help address them. With the group, we are talking about strengthening. We are talking about expanding. We are talking about practical way of achieving universal health coverage. And we are talking about the skill mix. We are talking about leadership. We are talking about advocacy. And I want to know from your point, you have been working there as a family physician, and then when you also meet together, you share ideas. So the advocacy aspect, what do you think you would do as an individual, and what do you advocate for those who are also in that position as medical superintendents to do to help get us to that place where family medicine becomes visible and practical? Our importance becomes so tangible such that people know. Let me say this. Currently, I and two residents in family medicine, we are working with the psychiatry unit on strengthening health systems among women and adolescents by integration of HIV, TB, and then mental health. And then the psychiatrist made a statement, say in South Africa, in addition, you cannot do without family physicians. And then when it came to the program, we were the people, when even one of them I couldn't go, they had to look for one of the residents to go with her. So advocacy, what in your capacity or where the opportunity that family physicians have as leaders, what can we do?
Thank you very much. I bring you greetings from President Sakeke, who is also a member of the group. I must say that at the executive level, medical executive, we are 6. 3 of us are family physicians. So, right, the family physicians are critical role. Let me also add that if you look at our database, yesterday I was checking our database, over 40 medical superintendents are family physicians. And I believe that especially the modular program of the Ghana College of Medicine has really been a game changer as far as training of family physicians is concerned. So I think that program should be strengthened, can have more family physicians in key positions. Most of the family physicians who are occupying are actually playing critical roles, ensuring that they're encouraging the young ones to also take up the responsibility or take up the opportunity to go to school, them to become family physicians. I'll use myself as an example. When the modular program started, I was part of the second batch. So in Bono East, let me say the former Bono region, I was the first medical superintendent to start the program. And as a result of my initiative I took, as we speak now, we have about 6 or 7 medical superintendents who are family physicians. And they are actually being district directors who are also family physicians within Bono region. So advocacy is ongoing, and we are doing very well to ensure that we push and then the objectives of family medicine very high on that. Now, let me add that to help us be able to achieve or get more people to be able to practice family medicine, we need to, as Bob was saying, we need to create that space. As we speak now, MDC has not accredited family medicine as a rotation. And it's one of the key things that we need to push and advocate for. Because I've been a medical superintendent for a very long time. I became a family physician 3 years ago. In my facility, I wanted to get accreditation for house job for doctors so that they can come there and practice their house management. Unfortunately, when we applied, NBC said that they do only the 4 main rotation, and that's medicine, pediatrics, and ops and gynae. But I think that as a group and then as leaders of the medical superintendents, we will need to push to ensure that we get accreditation from MDC to be able to enable doctors to come and then do house job in our various facilities. I think that when we do that, we'll be able to get more doctors to come into the practice. But when they come, they will see us, they will see the things that we do. They will understand the philosophy of family medicine, and therefore it will attract them to be able to practice. Again, Bob mentioned about designated space within our various facilities, and that is very key because we need to be visible. And one of the things that we've been advocating for is to designate our OPDs or our facilities as family medicine centers, so that anybody who enters the facility knows that this facility practices proper family medicine, not just general practice. So it's one of the things that I think that as a group we're also pushing to ensure that all facilities with family physicians have a designated space to enable people who come there know that family medicine is facilities. So that is what I will thank you.
So I'm thinking it, I'm still on advocacy. I know, like I said, South Africa became the first African country to adopt family medicine training. And then even the textbook that we use in family medicine training, we have them from South Africa. Community-oriented primary care also originated from South Africa. And they have brought to a point that you cannot deny that they are the backbone of the healthcare, primary healthcare. And over there, what they do is that family medicine, even at the undergraduate level, it takes a really good. They do rotation, 5 months rotation in family medicine, including a few in the others. And then my colleague specialist said, oh, in the districts, the family physician, they are their own anesthetists. And it's true. We can get there. So from GMA, advocacy to make sure that we are low and middle income country for the patient-doctor ratio, and then even with the experiences that we are talking about, where in the northern part we have challenges, policy-wise we have challenges even implementing some of the incentives. And then the aspect that we have even get heard from one of the ministers that they want the accreditation, they were denied. So I want to hear, if GMA have not even thought about it, what do you think can be done, and what can you carry forward to the leaders of Ghana Medical Association?
Thank you very much for the question. And I would like to take this opportunity to congratulate you on this occasion and for the very important topic that you have chosen for your stakeholder, I think, which is achieving universal health coverage through collaboration. That's a very important subject, especially in the current global environment that we are having aid cuts from major international partners. I am sure if you have been following the news, you know that one of the major funders worldwide is withdrawing funding from countries, withdrawing funding from the WHO, which is a major backbone for health promotion in the entire country. And this is a wake-up call to us in low and middle income countries to tighten our belts and make sure that we make concerted efforts to fill these funding gaps. So it's a very important topic that you have chosen. Now specifically to the you have asked me. Yes, the doctor-patient ratio in Ghana is concerning. And it is especially concerning in some parts of the country, such as the northern sector of the country and even in some districts. Now, the reason for which health workers do not accept posting to some deprived areas of the country are well known. Economic reasons, training opportunities for themselves and for their children. So all those are challenges that are well known. So in trying to mitigate this imbalance in distribution of health staff, we need to take measures that will address these concerns. And I think one of the major ways we can do that is approving the rural incentive allowance that GMA has proposed for several years. And we should approve that not just for doctors, but for all health workers, because it takes a team to run the district. So it's important to approve this allowance and make sure that we take into account economic benefits, education for the staff's children, and education for the staff that accepts posting to the district hospital. And let me just congratulate the female medical superintendent in the northern region for accepting posting. As GMA, I'm sure if you have followed our activities, you would have heard about some projects instituted in the Volta division of the country, whereby the division facilitates appointment of medical officers in certain deprived part of the allowance payments of the doctors. Other divisions, such as the Northern Division, are advised. I'm the chair, so we take steps towards that, to support what the government already pays these medical officers. So that if you have several sources of allowances, all these can add up to be something substantial, to be able to bridge the economic gap between you and those who are in the cities. And efforts should even be made to make sure that the economic benefits are even better, because that would be what will attract health workers, especially family physicians, to the district level. And it is important that we do away with this one-man station thing. Hospitals in which we have only single doctors, it is not good, because whenever that doctor wants to go for further studies, it becomes a problem getting in. We should ensure that in each district we have at least 2 or 3 doctors, so that a doctor leaving for further studies does not become improved. And I think that GMA would be willing to work with stakeholders to make sure that this. Now, family physicians, already your specialty in itself is one that can lead to burnout. I'm a pediatrician, and I see cases that are very well defined. You know that I'm seeing children with well-defined conditions. As a family physician, 1 minute you are seeing a child that you have to make calculations of drug dosages and fluids in milligrams per kilo, in males per kilo, and then the next minute you are seeing an old man with chest pain that may be a myocardial infarction. And then you turn and you are seeing a woman with abdominal pain that may be an ectopic. So your job is, so as we even advocate for you to go into the districts and health facilities, we ought to ensure that you have appropriate support from other health workers and doctors, so that you don't end up manning one-man stations, because that will add to your burnout. And psychiatric conditions and others are becoming a problem. We don't want to send you there so that you will end up with some of these conditions. So those are some of the things we can do at the level of the government and at the level of GMA. And I will take this opportunity to congratulate the Northern Division that has already taken the lead in this area. So with more collaboration, I'm sure.
So I want you to comment on the training aspect. But the prof is saying that we should advocate. And then where we have to get to a place where medical schools open up, and then we have more training. And so I'm looking at where we focus on best practices, where we think of, can we think of the 4 main: medicine, pediatrics, ONG, surgery, and then incorporate family medicine as part of the undergraduate and the housemanship rotations. That is the aspect I want you to share your ideas.
I think it's very important that having accepted family medicine for training at the specialist level, at the undergraduate level, we should also promote it, because it does not help in terms of number of people choosing that specialty when you are unaware of that specialty until after school, because the major rotations are what helps shape our interest in various specialties. And the previous speakers have all mentioned that family medicine is an important specialty, especially if we want to develop the healthcare situation in the district. So it will be important that at the undergraduate level, we already get medical students aware of family medicine as a specialty and get them interested in it. Now, at the postgraduate level, I have had some family physicians, residents rotating through my department. And from the onset, I have made it a point to ensure that they are part and parcel of the department during the period we are rotating through the department. There was a little backlash at the start, but now everybody understands. Because as a family physician, when a child presents to you, you ought to be able to manage most of the pediatric conditions and not just triage the child and send it to a pediatrician. And for this reason, I ensure that the residents rotating through pediatrics in the first 2 weeks are paired with my residents who they rotate with. And after that, they run their shifts alone. And they will be the senior most to supervise the house officers and also be the people who call the specialist or the head of the unit to discuss it. It is the only way in which can and come out as a family physician, you can attend to a child as a specialist and not a medical officer. So in terms of training, that is what I am doing. And it is also important that not only should family physicians rotate with pediatrics, I should also be able to send my pediatrician in families. And I think we should be working towards it because we do collaborate a lot. And one area that I am saddened is in the management of adolescents with chronic diseases. We should be able to transition these adolescents seamlessly to family medicine, but that's not the case. A lot of times, adolescent medicine is part of pediatrics. And I think that as children become adolescents, we should have a system where we work together to see these patients and eventually transition them to adult care. And I think family physicians are in our best place to play this intermediary role.
All right, thank you so much. So because of time, we didn't start with it. I would want maybe guys brief comment on the next question from all of you, and I'll open the floor for questions and then contributions. Prof said that we should take up the district off-campus training of medical students. So he has thrown the ball to us. So I want the deputy clinical care, deputy director clinical care, the MESHU. I think, I don't know the geographical dimension that UDS may send. And I also know that the dean of the medical school in UDS is the dean of deans, he's the head of the deans. So I believe that if what they are doing is really helpful, it is possible it can be replicated in the other regions. So what practical steps can we start thinking of to buy into his idea? All of you can comment, just a few seconds, then I'll open. This one will get me for 7 minutes.
Thank you very much, Dr. Moderator. So for us in Ghana Health Service, currently we actually collaborating. So yeah, I think I saw my desk a letter from the medical school communicating with us that they will be sending their students to some selected districts, within the region, and it's something that I actually came to meet. And then the only thing about this, and also basically based on my experience when I was in Central Regional was that when they come, they should also understand that the hospital is also within the community. But there seems to be some form of bias at the health directorates, where the students spend most of their time there and spend only 2 days within the hostel premises. I believe they need to find some common grounds to increase the stay within the hostels too, because that is where they are interested. Because if you want to contact time the students with family medicine, that is a very good opportunity. So I believe that if they can have a collaboration, in fact, my office is ever ready to support you in that regard. You can always communicate to the district directors and the medical superintendents to have a discussion to see how they can collaborate so that the students also have fair share of experience in the hospital, not only the district director, because the hospital is what is within the community. Thank you very much.
Thank you. So I'll let Prof comment last. No, you would let him comment last.
Thank you very much. I think that what we can do is for the medical schools probably sign an MOU with some of these facilities. We're talking about the fact that there are some of the students who go as far as so Kintampo is closer than and indeed, because of the College of Health training school for physicians, we also take up some of the physicians. So I believe that the school can engage the Ghana authorities at the regional level, and by extension to the hospital. We can equally be preceptors or teaching assistants to these students when they come to our places. And so I think that that is one of the key steps that can be taken. They are also fully on board. My suggestion would be, I mean, at the teaching hospital where the family medicine unit would be one of the, I don't know if they correctly would use few,
They don't spend much time.
okay, so that would mean that they should increase the time that is spent there, and I'm sure you will not have a challenge with teachers. Even the residents are going to be able to mentor and teach these students, so that what we are teaching the residents, they would also teach the medical students, and it will even be an avenue for them to learn what we are teaching them there.
Thank you.
I was just sitting down laughing at the way the suggestions are coming in. I think this very good suggestion, and it all fit into my speech or what I said. It will be very inappropriate not to increase the of students in district hospitals, but overly concentrates the community and households. So you need a blend of situation. You need to know what the household are doing, which we will concentrate on. But if they get to the hospital, what happens? I move around. What he's saying is true. At the time they have at the district hospital is only to say that, oh, these are the common diseases in that hospital. But if you are assessing them, they are not able to tell you much about what happened there. They are only interested in going to take secondary data, come and present and get their back. So we'll look at it. My friend, Kintampo is close to Tamale. I think maybe my dean has gone there. If not, visit the place, assess the place, send our teachers there, and then medical and dental council will do the accreditation. So that is how it goes. So we will visit you. You added something that can be very supportive, the College of Health. So we will look at it. Pediatric consultant, my junior brother. I think we were just, as if we decided to think alike when we're coming. Visibility and increase recognition and creation of awareness of family physicians within the teaching hospital is very important. So I've already said that they need to find a way of letting students rotate through there and not just to pass by, they should rotate. Thank you.
Thank you so much. Thank you so much. Let's give a round of applause for them. They've done so well. They've done so well. So 10 minutes. You have a question, you have a contribution. The time is open. The floor is open. Anyone with a question or contribution? So the announcement is that we want everybody to register so that we have the numbers for CPD, the names for CPD, and then the other things that we will need the names to use for the lunch and others. So if you haven't registered, please, the protocol team is there. You can let them know. Can you just let one of them come. Then you, while we are talking, you can just raise your hand. They'll bring the registrations to you. Then you register. So the discussion goes on. Next question or contribution. The floor is open.
Thank you for the opportunity. My name is Dr. Ben. I just have two concerns. They are just suggestions to buttress the points that were raised by my senior colleague, the medical superintendent, Dr. Anthony, on the table. The first one is with regards to medical superintendents or family physicians as leaders hospitals. I just want to emphasize that we need to really make a mark. A lot of our colleagues that are in management positions are really doing well with regards to they being family physicians and leaders as well. We have contentions these days with regards to the management of facilities. And a lot of other key cadre of staffs are contending with us with regards to whether even doctors are managing the facilities well. So I just want to emphasize, as family doctors, family physicians that are leaders, we should make a mark, because the time we are in turbulent times and all cadres of staffs are. Second point is that as family physicians who are either leaders of facilities or working within the facility, you may not be a leader. But there should be a difference that this is a facility that has a family physician. Sometimes you are done, and especially those in the district hospitals or maybe a regional hospital, you get there and you can't really tell if there's a family physician there or not. So if we are going to advocate, it goes beyond the speaking, but we must leave the talk that in our facilities we are there. Thank you.
Thank you so much. Thank you so much. Another question, contribution.
Thank you. My name is Famous Amusui, the resident.
I want to speak based on the experience from Thomas Teaching Hospital. When we started residency, house officers used to rotate through the department from internal medicine, where they come and spend a week or two before they go back to continue their rotation at internal medicine. They used to think the polyclinic is a place to go and rest. So they arrange it such that they do 1 week at emergency, accident and emergency. And then the following week, they are going to the polyclinic. And they come there and realize that the work there is probably even more than what they get at the A&E. And so they started complaining. At a point, they stopped sending the house officers because some of them said that when they come, we don't teach them. And the story was mixed. And this year, I know 2 of those house officers who passed through, wrote the primaries, passed, and were on the interview yesterday. I hope they get in. So what I want to suggest is this. We may not get accreditation accreditation from MDC to run family medicine as a full rotation. But like we're doing in TTH, house officers can spend some time out of the rotations that they are doing at the family medicine department. Maybe 2 weeks, 3 weeks. If you are doing surgery, 2 weeks, you come and spend that 2 weeks at family medicine. By the end of all 4 rotations, you have had about 8 weeks minimum in family medicine. And I think that can also help put us out there to attract more people. My divisional chair mentioned the fact that most doctors don't accept postings to rural areas or rural facilities because of a myriad of factors. One thing I want to add is poor road network. And that seems to be a major thing. You go to some of these district hospitals and you have to stay there because it's difficult to come back. And doctors, we don't have a lot of money. You buy your small car. By the time you enter there, you can't come out again. You go to the mechanic. So maybe at policy level, we can continue to push to make sure that, roads to these facilities are more travel. So that when the doctor goes there at the weekend, he wants to come to town and chill small. It's good for our mental health. Yes, we should be able to do that with it. Thank you.
Thank you. Thank you.
Thank you very much. I realize there's been a lot of discussion on house officers rotating from medicine. I might say that I have a meeting with is a very good friend, the MDC, on it. So very soon, we hope the house officer change through. The truth is that I don't think that it is right. Let me put it that way. People finish their house job and they are asked to go and work at the district when they are not rotated to family. Everything that they are going to do at the district is family. So we are actually going to push that they even make it compulsory. If they want medical officers to be working at the primary care center, then they should be well equipped to do that. But a lot of times, people finish with their house job, they get to the districts, and within the first 6 months to a year, they don't know what they are doing because they were not trained there and they struggle a lot. We think that it is right that if we are going to let our medical officers, go to the districts and manage the places, and sometimes go there they alone and work at that level, then they need to have some training under officers so that they can be able to manage comprehensively, continuously, and can be able to collaborate well. So be rest assured we are working on it, and hopefully very soon we're going to have house officers we take through. Thank you.
Thank you. Thank you. For the sake of time, he would be the last person, unless the executives want to make it a comment, or maybe the one person from the executive. Okay, go on.
Thank you. Sylvester Dancio, family physician at the TTH Polyclinic. this is a contribution, and I also hope there is something already going on about it. Just to comment on what Dr. Cosmos said, how to motivate doctors to come to include the deprived areas. He mentioned education, both for staff, and also their children and economic factors. There is a program we call Employee Assistance Program, where now facilities are looking at not just monetary terms, but how to help employees thrive in their organizations. So people are attracted to facilities looking at what they have for that program. And I think as doctors, right from medical school, it's assumed we are okay. We know ourselves, we can make our decisions right. And if we develop this employee assistance program right from medical school, providing guidance for students and also doctors, how to know who they are and where they can fit most. Going to work at the rural area is not always a punishment. Sometimes we are designed to thrive in such environments. And if we counsel doctors well, know the benefits they'll get there, they will come with a good mindset, not that I'm coming to sacrifice and suffer, but they rather thrive, and at the end of their time in that place, they'll live, very happy. This applies to even the so-called being called as a missionary. Now, missionaries are getting counseling. Some go to places in the name of, I'm going to serve God and sacrifice. Then they realize that it's not as they think. But if they get proper counseling and guidance, they have a better mindset and they rather thrive over there. And I think we can take it up and see how we can develop such program to also attend to doctors to know themselves and they know where they fit most and expect to try wherever they go. Thank you.
Thank you so much. So let's give a round of applause for the audience and the stakeholders. We are so grateful that you came to make this occasion memorable. And I know we have not get stopped. There are deeper things that we believe that it's possible to look at them and then get them implemented. So we want to invite the cultural troop, but we put Canada that you go back so that they can come and display. After the cultural troop, 5 minutes, then we'll have the pharmacy group to come in and then we call it. We are done with this morning's program. Thank you so much. Thank you so much. Hello, so we have one of our sponsors to present to us. So let me give him an attention. Thank you.
So hi everybody, good morning. Please, how are we? Great. So I'm a bit tensed, so I'm looking around the room to find the doctors from Kolebu Polyclinic, so that at least I know a few faces. I see Dr. Chenebo, I see Dr. Mordecai, I see Abna Kare before, and a couple of others. It's surprised I know her. Yeah. So please, thank you so much for the opportunity to be here. Because the slides are behind me, I may come forward a bit just so that I can see what's being displayed. Can the slides be displayed? So my name is Nathaniel Niamasa. I'm a pharmacist with Expar Pharmaceuticals. Expar Pharma which is a Belgian company in Ghana. So being a Belgian company, that implies that we are from Europe, and consequently, we adhere to the European standards of good manufacturing practices. Hence, every product from Expa, which you give to a patient of yours, you are sure is of the best quality that you can find on the market. However, please next slide. However, even though we are a European company, we are very, very sensitive to the African market. Hence, over the past 40 years, we have been in Africa, and currently we are now moving into the English-speaking space. That's why you're seeing Expa here. We've been in Ghana for close to a year, and we've been interacting with doctors since. Next slide. So in Ghana, we just have this very small portfolio made up of 8 products. There's our pain portfolio. The purposes of what we would be talking about this morning will be focused on just 2 of our portfolios, being our pain portfolio comprised of Antalgex T, which is our tramadol paracetamol formulation, and then also Exit, which is our brand of celecoxib. And then for pediatrics, because you are general practitioners, or pardon me to say that you are family physicians, we'll be looking at 2 of our pediatric formulations, being Febelex Plus and Febelex Junior, and then we will see how your patients can benefit from the same. So typically when we do our presentations, we tell a story, one that you've heard over and over and over again. A patient comes to the OPD and their main complaint is that they are in pain. Now, it's been shown that pain is a very serious issue for our patients, and we can't say otherwise. Most of the patients who are going to come to the OPD, as we know it, are going to be reported because they have pain. As Ghanaians, we know that till a person has some pain, they would never show up in the OPD. It's also been shown that most of our patients typically are more scared of pain when they think about surgery than even the fear of death itself. So you find that even as you're talking about surgical procedures and all that, most patients fear the pain that is associated with surgeries than death. And consequently, that means that most of them are more resistant to surgical procedures only because of the pain that is associated with that. And that is only because their pain is not adequately managed in that regard. So somebody will say that why is it essential that we as clinicians manage the pain of our patients? Basically, we have to know as clinicians that pain being the main thing that directs our patients to us also implies that it significantly impacts the quality of life of our patients. Most patients who come to the clinic, if they don't have their pain well managed, it affects them in various ways. For instance, it affects their productivity at work because most of them do not want to return to work in time. Most of them have to use so much to buy various medications. You realize that more often than not, you have to use one medication for, say, more months because you want to get some better efficacy than what they are getting over the time. And this basically causes the patients more. Additionally, most of our patients whose pain is not managed well are prone to developing various chronic pain conditions, associated with their chronic pain. For instance, most of our patients may develop traumatic events as a result of being stationary due to their pain. Now, when you as a clinician manages the pain of your patient adequately, what you are doing is that you are improving their quality of life. You're making sure that they can return to work as quick as possible. You're making sure that they don't use so much money to manage their pain. And most important, don't expose them to the risk of developing various untoward conditions. Now, it is important to note that even when we are while managing the pain of our patients, it has to be holistic such that we are not looking just at our pharmacological available options, right? Now, the pain the association advocates that as much as possible as patients, we should try as much as possible to use various modalities, using what we call the multimodal approach, that is using both pharmacological and non-pharmacological approaches to manage our patients' pain and optimize the outcomes that we have in that regard. So in that regard, we're going to have the usual non-pharmacological therapy and then also the pharmacological therapy in that regard. And one thing to know that is the fact that we are advised that when giving pain medications, oral medications or IV, whichever it is, should as much as possible try to use the least dose of the medication, which will give them the highest efficacy and the least side effects. So it's more like a triangle that we are thinking about, something that gives them the highest effect at the lowest dose and also points them to the fewest side effects possible. And as much as possible, we should try to use an NSAID or acetaminophen and then add an opioid to manage their breakthrough. Now, it will surprise you to know that even though you are doing all these things in the clinic, it has never been enough. And sorry to say, it really would not be enough going forward. There's another aspect that we are falling into from expert, that is a higher level, something that is based on the human being, making sure that the patient that is sitting in front of you is not getting medication only because it's the medication that comes off the top of your head, but rather because it's the medication that is right for that patient in front of you. And the only way we can describe it is intentionality. That is the extra step we are asking for. And what does intentionality mean? Basically, intentionality is asking that each patient who comes to you, the ideal solution for such a patient should be something that gives the patient the fewest side effects, something that gives them adequate pain relief, something that has a fast onset of action, something that gives them all day pain coverage, and something that you may not even think about is the fact that most patients consider medications that are very easy to swallow. And if you look at all these things, typically you will not find it in one medication, except in anti-AGSM. Now, anti-AGSM, which is capsule formulation, is a tramadol paracetamol combination, 37.5 of tramadol and 325 paracetamol. And I know many of you are already thinking in your head that, oh, that's something we know. But it will surprise you to know that the capsule formulation basically optimizes outcomes in your patients. Now, how does it do this? With this capsule formulation, your patients are going to get a faster solution, and then consequently, they are going to get a faster onset of action. This means that patients don't have to wait for so long before they get their medications working for them. Additionally, because it's a capsule, they tend to tolerate it better because most patients will not be able to taste the medication. That means that side effects such as nausea, such as vomiting in your patients would be avoided in that regard. Also, because it's a capsule formulation, the bioavailability is higher because the capsule is going to release all the medication in solution. What this means is that with a single capsule of anti-AGSM, a patient can get as much pain relief as when they take 2 tablets or a tablet and half of any other brand that you're used to out there. This means that the patients are getting value for money, they're getting more pain relief, and then consequently, they are not suffering the side effects. So, when you think about something that gives your patients adequate relief without exposing them to side effects like you're looking for, then you're thinking about anti-AGSM. So, just to bring your mind to everything you've been saying, all I've been saying is that, so before I go to that, this slide basically speaks to the 37.5 and 325 of paracetamol. I understand most clinicians worry as to why we use such low doses of tramadol and then paracetamol. Basically, there are studies that show that when the two medications are put together in such a low dose, they have what we call a supra-additive effect. That is to say that they tend to give you more benefits as compared to even using 100 milligram or 50 milligram plain tramadol in your patients. So your patients tend to benefit more from the capsule formulation in this regard. The next. All right. So when it comes to the dosing, what we advise basically is a 1 TDS dosing. We advise that because patients are going to benefit from a single capsule more than they would with other formulations, don't overburden them if they don't need too many capsules. Just give them a 2 starts in the acute phase and then revert to your 1 TDS. What this does also is that it saves your patients more on the amount of money that they have to use on their medications. So in summary, all I've been saying is that pain is a very serious issue for you. It impacts the quality of life of your patients significantly. And in managing the pain of your patients, you should, as much as possible, try to use all available options to you. And then most importantly, we are saying today that when you are looking for a medication to manage the pain of your patients, you're supposed to look for something that gives them the fewest side effects, something that gives them all the pain coverage, something that has adequate efficacy and fast onset of action. And most importantly, to most of our patients, we find that they want something that is easy to swallow and prevent them from getting those untoward side effects of nausea and vomiting. And when you think about all these things, when you give this conference and you ask for a medication that does all these in one patient, then anti-AGSM is the medication you're thinking about. So that's with anti-AGSM. So we take a little breath. So our next option, because you are family physicians, we know that always you are looking for solutions to make the lives of your patients simple. And one typical condition that most parents will bring their children in for adults is typically pain. For children, it's usually the flu that would bring the kids to the clinic. Now you realize that when a child comes in with the flu and they are having all the symptoms. They are having the cough, they are having the fever, they are having the headaches, the body aches, they are having the runny nose, the stuffy nose. Typically, as a clinician, when you think about managing them, you're looking to manage only the symptoms of the medication of the problem, because typically it's a viral infection, right? So you wouldn't want to use your antibiotics, but you want to manage the symptoms. Now, what this asks of you as a clinician is that you are combining different medications to tackle the various symptoms. For instance, if you want to tackle the fever, you are looking at putting in some paracetamol. If you're looking to tackle the allergies, you are looking at something that is an antihistamine. If you're looking to tackle the runny nose or the stuffy nose, you probably are thinking about a nasal drop, right? Now, this patient is going on with 3 medications, and I've seen instances where one child is going on with at least 5 medications because the child additionally has a cough and also has to take home some vitamins. Now, what this does to the children is that, let's imagine a child like myself who is very stubborn, who was very stubborn growing up. Now, it means that the mother has to chase the child every time she wants to give those 5 medications. Now, imagine chasing one child for the first medication, for the second, for the third, and there are 2 more medications left to chase the same child. That is going to be very cumbersome for the parent. Additionally, what the patients have to pay more for all those medications that they are using for just one child. Now, what we as experts are saying is that your children don't have to bear this kind of crime only because they are having what a flu. So, what we have for you from expert is our Febrilex ranges, our Febrilex Plus and our Febrilex Junior Syrup. Now, with Febrilex Plus, what your patients are getting is paracetamol, they are getting chlorpheniramine, and then also they are getting dextromethorphan in the same formulation. So that when a child sits in front of you and they have flu symptoms, in addition to a dry cough, with just one medication, you manage all their symptoms without having them to go and take different bottles with different tastes. On the other hand, if the child does not have a dry cough at all, then Febrilex Junior serves the purpose with its paracetamol and chlorpheniramine. Now, if a patient presents in the clinic and the presentation is such that the child is having fever, chills, body aches, typical symptoms of a flu, we are asking that you ask your patient 3 questions for us. The first question is that, does the child have a cough or not? If the child does not have a cough at all, any age at which the child presents without a cough, you typically will not need a cough syrup. So in such an instance, something like Febrilex Junior, which has paracetamol and chlorpheniramine, will be suitable for managing their symptoms, right? Now, if the child has a cough, you go on and ask your second question, is the cough a dry or a wet cough? If it's a wet cough, typically you wouldn't want to stop such a cough. Rather, you want to encourage it so that the flames can be brought out, or if it's not so severe, then it's self-limiting. We are just going to leave it until it goes away. In such an instance, you can still use your Febrilex Junior, which has just paracetamol and chlorpheniramine, to tackle the flu symptoms. And if it's a severe cough, which is having some phlegms, then you can add an expectorant in that regard or not. And then, if the cough is dry, then you ask our last question, which is the child above 6 years, or in some instances above 4 years, or less than that? If the child is less than 4 years or 6 years, then you wouldn't want to suppress their cough because cough suppressants are contraindicated in such populations, right? So in such an instance, just stick to the Febrilex Junior. However, if the child is more than 4 years, then you can use Febrilex Plus with its dextromethorphan because the child will benefit from the same. So what are we saying this morning? We are saying that if you have a child who sits in front of you with flu symptoms, now you are thinking about all the many medications that you can give to this one child. Stop for a moment and think that this child is just one human being who is going to take all these medications. Take a pause and then think about Febrilex Plus and Febrilex Junior, knowing that with one formulation, your child is going to get all that they need to cater for their symptoms, and then they wouldn't be burdened so much. At this point, I'll say thank you. Take your questions.
So 3 minutes questions for him.
That was fast.
Morning, thank you very much for the presentation. I want to talk about the antalgics.
Antalgics tea, yes.
And just so that you add discussion, you need to titrate to effect. Yes, I know you don't want to burden the patient with many capsules, but you need to also determine what the rate of pain is, so that we're able to tackle that.
Thank you so much. So please, as a note, I'd like to add that the dose we recommend is also specialty dependent. For people in primary care, more often than not, the pain score may not be so much at times. So you may use, a patient may benefit just from one capsule. For neurosurgery, for instance, pardon my ignorance if that is the case. For neurosurgery, I know that they conventionally use 2 capsules for most of their patients. So it's like she said, you'd titrate accordingly, don't be stuck to the dose.
So the second thing about it is that, can you talk a bit about the habit forming using
Okay. Right. So regards to the habit forming nature of opioids, right? So initially we have the study that basically says that patients, before they get to the habit forming point, really go through a phase of dependence where they want a particular effect from the medication, and that's why they will seek it, eventually drop into habit forming or addiction. Now, the thing with anti-AGST is that because it's a capsule formulation, patients benefit more from a single capsule. More often than not, you don't have patients looking for additional capsules. So a doctor doesn't have to do 2 or 3, and then a patient maybe feels a particular way. So what we found is that even on a single capsule of anti-AGST, in some instances on 2, patients don't have those side effects of the dizziness, the euphoria, and all those that they have with other medications. So I'll say that it's more tolerable and it's on the lower side as exposing a patient to that risk.
All right. But the issue of primary case, all kinds of cases, those who have mild pain, those are issue are coming to primary care. Those higher with high pain, we are going to the specialist. So it is assessing the pain score, like she said. That will determine how you start, and then that is the best we would want to approach it. And then further comment or question.
Thank you very much. I don't know about my habits, but I'm hearing these drugs for the first time. So I want you to talk about availability and also cost.
So please, if you can put up my slide, the last one.
Kamale is
so availability for facilities such as the one before this, such as Kolebu, CAT, all the facilities in there we are present. For the pharmacies, we know that there are some that are big pharmacies, so like Ad Pharma, like Top Up, like Origin, East Cantonment's pharmacy, your patients can get them from all those places. But these are currently mostly government facilities that we already gain access into. There are a whole lot of other private facilities that we are present.
So middle belt and
so for the middle belt,
the
middle belt and northern, my colleague here at the back will follow up and then ensure availability in that regard.
All right.
So pertaining to the cost, so your patients are getting it at a capsule for 7 cities, please. A capsule for 7 cities. So that's a box for 140. 140. That's 2 patients at the retail end. Now for the facilities, I think since we have some superintendents here as well, we know that most pharmaceutical companies have access prices for facilities. So you find that in some facilities we are selling as low as 6 cities in most of those facilities. That is 120 for a box, only because the facility is high.
All right, 2 minutes. Any other comment or question? Okay, so thank you so much for coming all the way from the South. So we thank you so much. So we are, what is when we come to the end of the stakeholder. So what we want to do is we want to take pictures with our invited guests. Then after that one, we would, there's snack out there. You can, while you go out, you can take whatever is available there that you want. the pharmaceutical companies, some have also displayed, so pass by the table. Those who have displayed their products, you can pass by. We are lunch is at 1. Then we are reconvening here at 2:30 for the CPD in the afternoon. So thank you all for the cooperation and the support that you have given me for this morning program. We will invite for vote of thanks, and then we'll start the pitches. So from the pharmaceutical company, those in Tamale here, we have the products at Gina Pharma. And so that is close to the, I think Gina Pharma they have many branches. We have some around the hospital and then within town. The cocktail would be in the evening, and we have one of us, Brigadier Annan, who has graciously sponsored the cocktail. And I would also add, I didn't ask for permission to mention her name, but one of us came and helped add some beauty to the decoration that we have here. So since I didn't ask for permission, I will not mention her name, but if I get the permission, then we can. So let's give a round of applause for her. Oh, sorry, is Brigadier General Anna. So we have to recognize. I've been told I didn't pronounce the qualification very well. Brigadier General Anna. So if I am safe in Tamale, I'll get one to him when there's a trouble. All right. So vote of thanks. So let's invite Ekuya. Is Ekuya here?
So we would like to thank the Almighty God first for allowing us to have such a nice program. And then to our panelists, we want to say a very big thank you for sharing more insights and throwing more light on how to achieve universal health coverage through collaboration. And then to our indefatigable president, Dr. Nketia, we saw you in action today. And to all support executives, we say Ayiko, and thank you for organizing such a wonderful program. And to all support members and all here present, we say thank you for being such a wonderful audience. All I have to say is bye to all of you.
Good. Thank you. Thank you. So the cocktail, the band leaves here at 6:30 to So the band leaves here at 6:30 to the Air Force Base. So if you are also driving there by yourself, you have to also be on your way from at that time. All right, so we want to take pictures. So please come and then a minute. Okay, so we will take the closing prayer and then we to the